Z-Medica develops, manufactures, and markets innovative hemostatic devices to support a broad range of applications and markets around the world. Our mission is to save lives and improve patient outcomes by offering a hemostatic solution that leads to faster bleeding control. QuickClot is a proprietary technology which consists of a non-woven material impregnated with kaolin. There are three main categories of methods to control bleeding: standard gauze and lap pads, active hemostatic agents, and passive hemostatic agents. QuickClot products provide hemostasis like a hemostatic agent with the placement ease of a standard gauze or lap pad. The novel technology enables maximum absorption and promotes robust clot formation. Kaolin is the unique differentiator for all QuickClot products. Kaolin is an inorganic mineral that works on contact with blood and accelerates the body's natural clotting ability. The contact between negatively charged kaolin and blood activates factor 12 on the intrinsic pathway. This, in turn, accelerates the body's natural clotting cascade. Leading to robust clot formation and faster bleeding control. QuickClot products have a track record of success, starting in the military as the hemostat of choice. QuickClot products have since expanded across a broad range of segments and bleeding scenarios. For faster time to hemostasis and significantly less blood loss, it's QuickClot or it's not.
Combat Application Tourniquet, or CAT. Two-handed application. In life-threatening situations, the items in this bleeding control kit are designed to provide you with simple yet essential medical equipment to stop severe bleeding. Empower anyone to assist in life-threatening situations. Now you can easily prepare yourself for the unexpected. Lives are depending on it. Gloves should be worn during the application. To begin, remove the CAT from the bleeding control kit. For best results, expose the skin where the wound is located. For this two-handed application, pull the band out of the CAT buckle. Route the band around the limb. Position the CAT 2 to 3 inches above the bleeding site, applied directly to the skin. Pass the red tip through the slit of the buckle. Pull the band tightly and fasten it back on itself all the way around the limb, but not over the rod clips. The band should be tight enough that the tips of 3 fingers cannot slide between the band and the limb. If the tips of 3 fingers slide under the band, retighten and re-secure. Twist the rod until the bleeding has stopped. Secure the rod inside a clip to lock it in place. Check for bleeding and distal pulse. If bleeding is not controlled or distal pulse is present, consider additional tightening or applying a second CAT above and side by side to the first. Reassess. Secure rod and band with time strap. Record time of application on the time strap with the permanent marker included in the kit. Assure the patient that help is on the way. Combat Application Tourniquet, CAT, one-handed application. Insert the injured limb through the loop in the band and position the CAT 2 to 3 inches above the bleeding site, directly to the skin. Pull the band tightly. Fasten it back onto itself, all the way around the limb, but not over the rod clips. The band should be tight enough that the tips of 3 fingers cannot slide between the band and the limb. If the tips of 3 fingers slide under the band, retighten and resecure. Twist the rod until bleeding has stopped. Secure the rod inside a clip to lock it in place. Check for bleeding and distal pulse. If bleeding is not controlled or distal pulse is present, consider additional tightening or applying a second cat above and side by side to the first. Reassess. Route the band between the clips and over the rod. Secure rod and band with time strap. If able, record time of application on the time strap with the permanent marker included in the kit. Combat Application Tourniquet. CAT. Storing the CAT in the quick launch configuration. Take the band out of the buckle. Ensure the rod is not secured in the clip and all turns of the rod are removed. Stretch out the band twice, horizontally, like an archer, to straighten it out. Pass the red tip through the slit in the buckle. Pull 8 inches of the band through. Fold it back and adhere the band to itself. Flatten the loop band. Place the buckle in the middle of the flattened band. Fold the CAT in half, placing the buckle at one end. Secure the rod inside a clip to lock it in place. The CAT is now ready to be used for future training. These are some important points to remember. Never place a tourniquet over a joint, such as a knee or elbow. The tourniquet can be applied over clothing. If the site of the bleeding is not readily apparent, place the tourniquet high and tight, as proximal as possible, on the injured limb. Never use the tourniquet over items in your clothing. For larger limbed persons, 2 tourniquets may be used, but must be applied side by side, with the rods not interfering with each other. Once again, the band should be tight enough that the tips of 3 fingers cannot slide under the band.
Z-Medica develops, manufactures, and markets innovative hemostatic devices to support a broad range of applications and markets around the world. Our mission is to save lives and improve patient outcomes by offering a hemostatic solution that leads to faster bleeding control. QuickClot is a proprietary technology which consists of a non-woven material impregnated with kaolin. There are 3 main categories of methods to control bleeding: standard gauze and lap pads, active hemostatic agents, and passive hemostatic agents. QuickClot products provide hemostasis like a hemostatic agent with the placement ease of a standard gauze or lap pad. The novel technology enables maximum absorption and promotes robust clot formation. Kaolin is the unique differentiator for all QuickClot products. Kaolin is an inorganic mineral that works on contact with blood and accelerates the body's natural clotting ability. The contact between negatively charged kaolin and blood activates factor 12 on the intrinsic pathway. This, in turn, accelerates the body's natural clotting cascade. Leading to robust clot formation and faster bleeding control. QuickClot products have a track record of success. starting in the military as the hemostat of choice. QuickClot products have since expanded across a broad range of segments and bleeding scenarios. For faster time to hemostasis and significantly less blood loss, it's QuickClot or it's not.
Combat Application Tourniquet, or CAT. Two-handed application. In life-threatening situations, the items in this bleeding control kit are designed to provide you with simple yet essential medical equipment to stop severe bleeding. Empower anyone to assist in life-threatening situations. Now you can easily prepare yourself for the unexpected. Lives are depending on it. Gloves should be worn during the application. To begin, remove the CAT from the bleeding control kit. For best results, expose the skin where the wound is located. For this two-handed application, pull the band out of the CAT buckle. Route the band around the limb. Position the CAT 2 to 3 inches above the bleeding site, applied directly to the skin. Pass the red tip through the slit of the buckle. Pull the band tightly and fasten it back on itself all the way around the limb, but not over the rod clips. The band should be tight enough that the tips of 3 fingers cannot slide between the band and the limb. If the tips of 3 fingers slide under the band, retighten and re-secure. Twist the rod until the bleeding has stopped. Secure the rod inside a clip to lock it in place. Check for bleeding and distal pulse. If bleeding is not controlled or distal pulse is present, consider additional tightening or applying a second CAT above and side by side to the first. Reassess. Secure rod and band with time strap. Record time of application on the time strap with the permanent marker included in the kit. Assure the patient that help is on the way. Combat Application Tourniquet, CAT, one-handed application. Insert the injured limb through the loop in the band and position the CAT 2 to 3 inches above the bleeding site, directly to the skin. Pull the band tightly. Fasten it back onto itself, all the way around the limb, but not over the rod clips. The band should be tight enough that the tips of 3 fingers cannot slide between the band and the limb. If the tips of 3 fingers slide under the band, retighten and re-secure. Twist the rod until bleeding has stopped. Secure the rod inside a clip to lock it in place. Check for bleeding and distal pulse. If bleeding is not controlled or distal pulse is present, consider additional tightening or applying a second CAT above and side by side to the first. Reassess. Route the band between the clips and over the rod. Secure rod and band with time strap. If able, record time of application on the time strap with the permanent marker included in the kit. Combat Application Tourniquet, CAT, storing the CAT in the quick launch configuration. Take the band out of the buckle. Ensure the rod is not secured in the clip and all turns of the rod are removed. Stretch out the band twice, horizontally, like an archer, to straighten it out. Pass the red tip through the slit in the buckle. Pull 8 inches of the band through. Fold it back and adhere the band to itself. Flatten the loop band. Place the buckle in the middle of the flattened band. Fold the cat in half, placing the buckle at one end. Secure the rod inside a clip to lock it in place. The cat is now ready to be used for future training. These are some important points to remember. Never place a tourniquet over a joint, such as a knee or elbow. The tourniquet can, if the bleeding is not readily apparent, place the tourniquet high and tight as possible on the injured limb. Never use the tourniquet over items in your clothing. For larger limbed persons, 2 tourniquets may be used, but must be applied side by side, with the rods not interfering with each other. Once again, the band should be tight enough that the tips of 3 fingers cannot slide under the band.
Z-Medica develops, manufactures, and markets innovative hemostatic devices to support a broad range of applications and markets around the world. Our mission is to save lives and improve patient outcomes by offering a hemostatic solution that leads to faster bleeding control. QuickClot is a proprietary technology which consists of a non-woven material impregnated with kaolin. There are 3 main categories of methods to control bleeding: standard gauze and lap pads, active hemostatic agents, and passive hemostatic agents. QuickClot products provide hemostasis like a hemostatic agent with the placement ease of a standard gauze or lap pad. The novel technology enables maximum absorption and promotes robust clot formation. Kaolin is the unique differentiator for all QuickClot products. Kaolin is an inorganic mineral that works on contact with blood and accelerates the body's natural clotting ability. The contact between negatively charged kaolin and blood activates factor 12 on the intrinsic pathway. This, in turn, accelerates the body's natural clotting cascade. Leading to robust clot formation and faster bleeding control. QuickClot products have a track record of success, starting in the military as the hemostat of choice. QuickClot products have since expanded across a broad range of segments and bleeding scenarios. For faster time to hemostasis and significantly less blood loss, it's QuickClot or it's not.
Combat Application Tourniquet, or CAT. Two-handed application. In life-threatening situations, the items in this bleeding control kit are designed to provide you with simple yet essential medical equipment to stop severe bleeding. Empower anyone to assist in life-threatening situations. Now you can easily prepare yourself for the unexpected. Lives are depending on it. Gloves should be worn during the application. To begin, remove the CAT from the bleeding control kit. For best results, expose the skin where the wound is located. For this two-handed application, pull the band out of the CAT buckle. Route the band around the limb. Position the CAT 2 to 3 inches above the bleeding site, applied directly to the skin. Pass the red tip through the slit of the buckle. Pull the band tightly and fasten it back on itself all the way around the limb, but not over the rod clips. The band should be tight enough that the tips of 3 fingers cannot slide between the band and the limb. If the tips of 3 fingers slide under the band, retighten and re-secure. Twist the rod until the bleeding has stopped. Secure the rod inside a clip to lock it in place. Check for bleeding and distal pulse. If bleeding is not controlled or distal pulse is present, consider additional tightening or applying a second cat above and side by side to the first. Reassess. Secure rod and band with time strap. Record time of application on the time strap with the permanent marker included in the kit. Assure the patient that help is on the way. Combat Application Tourniquet, CAT, one-handed application. Insert the injured limb through the loop in the band and position the CAT 2 to 3 inches above the bleeding site, directly to the skin. Pull the band tightly. Fasten it back onto itself, all the way around the limb, but not over the rod clips. The band should be tight enough that the tips of 3 fingers cannot slide between the band and the limb. If the tips of 3 fingers slide under the band, retighten and re-secure. Twist the rod until bleeding has stopped. Secure the rod inside a clip to lock it in place. Check for bleeding and distal.
Hi, good morning, good afternoon, everyone. Thank you for joining us for this is the 6th CME trauma for organized by Mascot. So I'm very glad there's a lot of participation this month. So this month we are going to have two speakers. And the topic is very interesting, which is regarding blood transfusion in trauma, as you can see. So we have two speakers, which is one is Dr. Rantini. Dr. Rantini will be presenting regarding targeted transfusion protocol in major trauma resuscitation. And we also have Dr. Sarojini Epimanya, who will give a talk regarding, give a talk regarding revisiting the massive transfusion protocol trauma and a back-end perspective. So without further ado, I would like to invite Dr. Ratini if she's ready. Dr. Ratini, are you ready? Dr. Ratini?
Yes, yeah.
Okay.
Okay. Good evening, everyone. Welcome to the Trauma CME series for June 2021. I'm Ratini Dhiren, a practicing emergency physician from Kuala Lumpur General Hospital, and I'll be talking on targeted transfusion protocol in major trauma resuscitation. All right, so hoping at the end of this presentation, we all can have a great idea on the limitations and strengths of acute traumatic coagulopathy interventions. At the same time, have a greater competence in selecting appropriate treatment of acute traumatic coagulopathy. Basically, throughout the decade, our understanding of mechanisms of coagulation has shifted from actually a simple enzymatic cascade to a very complex cell-based paradigm in which there's evidence-based biochemical changes in the endothelium, erythrocytes, leukocytes, and platelet interact to coordinate a very delicate balance between thrombosis and fibrinolysis. Treatment algorithm for traumatic coagulopathy have emphasized in replacing both clotting factors as well as platelets with concomitant restraint of crystalloid administration. Also in the term, there's the management of damage control resuscitation, as well as adding pharmacological adjuncts that exploit the endogenous coagulation system. Purity in the post-injury chemotherapy and hemostasis, as has mentioned in the 7th edition Trauma by McGraw-Hill, there were numerous documentations of deleterious effects of overzealous blood component replacements that has actually led to a reevaluation of strategy in an attempt to reach actually a balance between the abatement of coagulopathy as well as minimization of subsequent organ dysfunction. In terms of trauma-related bleeding and death, there's actually severe bleeding documented in every 1 in 10 deaths. Uncontrolled post-traumatic bleeding is actually known as the #1 cause of preventable deaths among injured patients. 1/3 of all patients who present to the hospital with severe bleeding show signs of coagulopathy. This was actually mentioned by Spahn in the Journal of Critical Care in 2019. Okay. Oinini further describes in the Journal of Injury in 2017, it was conducted in the Level 1 Trauma Center in US. The leading causes of death, which is predominantly head injury, followed by hemorrhage, cardiac, multi-organ failure, sepsis, and subsequently respiratory failure and pulmonary embolism. This study was done between the years of 2012 and 2013. In Malaysia, as reported by the Department of Statistics, has studied the causes of major death in 2017 and 2018 and has described that transport accidents are actually the 4th leading cause of death in our country, predominantly in the age group between 15 to 40 years old. The PRO-PPR trial by Halcom, as described in JAMA Journal 2015, with regards to transfusion of plasma, platelets, and RBCs between a 1:1:1 versus a 1:1:2 ratio, and the mortality in patients with severe traumatic injury, actually described that exsanguination, which was the predominant cause of death within the first 24 hours, is decreased in the 1:1:1 group as compared to the 1:1:2 group, maybe because of achieving early hemostasis. However, there's no significant difference in the mortality at 24 hours or at 30 days. Subsequently, Subsequently, Chang described in the Journal of Journal of Trauma Acute Care Surgery, which actually followed up regarding to the PRO-PPR trial, which is entitled "Earlier Time to Hemostasis is Associated with Decreased Mortality and Rate of Complications." This predefined hemostasis as no intraoperative bleeding requiring intervention in the surgical field or resolution of blush on DIR. In the 408 patients conducted, 87% of them in every 15 minutes actually had a reduction of time to hemostasis and had a decrease in 30-day mortality, as well as decrease in the acute respiratory distress syndrome, multi-organ failure, as well as sepsis, but not the venous thromboembolism. Right? Describing acute traumatic coagulopathy has gone way back and has been described in the Journal of Trauma and Acute Care Surgery in June 2003 by the famous Prof. Karim Borhi, and it's gone through a decade of changes and better understanding. right? So traumatic induced coagulopathy, it has got two components following injury. First one, known as acute traumatic coagulopathy, which what happens there is hyperfibrinolysis and hypercoagulable state. Subsequently, once the mechanism of trauma has occurred, the subsequent phase that occurs is the resuscitation-assisted coagulopathy, of which there is dilutional, acidosis, hypothermia, and consumption of coagulation factors, right? So when a traumatic event has occurred, adding on hypoxia to it, which further stimulates endothelial dysfunction, subsequently stimulating tissue plasminogen activator that stimulates plasmin to actually causes the clot degradation. This was described in the Ultra Power Health in 2018. Right? In the Journal of Trauma Acute Care Surgery, described by Moore, as you can see the arrow on the left, there are multi-factors that also add on to this event, such as genetics, comorbidity of the patients, underlying medications, acidosis, hypothermia, and dilution. Okay, so once again, traumatic event associated with tissue injury and hypoxia causes endothelial dysfunction. Subsequently, the protein C becomes activated. It causes the binding of thrombomodulin with thrombin, causing a thrombomodulin complex, which subsequently inhibits factor 5A and factor 8A, at the same time stimulating tissue plasminogen activator, heparin sulfate from the glycocalyx of the endothelium, causing factor consumption as well as platelet dysfunction, and all these play a role in reducing the clot formation. Right? In the same journal as described by Moore, in the Journal of Trauma Acute Care Surgery, there's actually two different types of phenotypes that is also affected in the trauma-induced coagulopathy. Right? And Hayakawa has actually described that the fibrinolytic phenotype is actually causing the disseminated intravascular coagulation in understanding the pathophysiology of trauma-induced coagulopathy. Okay. So he basically describes there are two different types of DIC phenotypes. One is the fibrinolytic phenotype, and the other is the thrombotic phenotype. Okay. In both pathways is actually activated by coagulation. Okay. But in the fibrinolytic phenotype part, there is actually inhibition of the plasminogen activator inhibitor 1, which is low in the fibrinolytic but is high in the thrombotic phenotype. So therefore, you get a bleeding pattern in the fibrinolytic phenotype, but organ dysfunction in the thrombotic phenotype. Okay, this was published in the Journal of Intensive Care 2017. Next, we go on to the usage of antifibrinolytics. Right? In the management of major bleeding and coagulopathy, European guidelines update the 5th edition in recommendation number 22, evidence grade 1A, states that a trauma patient who is bleeding or at risk for major hemorrhage should have transuranic acid as soon as possible within 3 hours. A loading dose of 1 gram infused over 10 minutes, followed by IV infusion 1 gram over 8 hours. And the first dose should be en route to the hospital, not waiting for results from a viscoelastic assessment. The famous CRASH-3 trial, which studies the transuranic acid use in traumatic brain injury, studied a population of almost 12,737 patients from 175 trauma centers, and studied the head injury-related deaths in hospital within 28 days of injury, and this was published in the Journal of Lancet 2019. Right? What were the outcomes in terms of head injury-related death within 3 hours of injury? And actually, it showed an improvement in almost all patients, except for those with the GCS score of 3 or bilateral unreactive pupils. Recently, there's been a lot of discussions with regards to the CRASH 3 trials in terms of stating there were lack in actually assessing the fibrinolytic pathway in those patients that come with major trauma before using tranexamic acid. But if you follow European guidelines, it's still advocated to just give the IV tranexamic acid as for now, right? What about in a pediatric population? Okay, it's published in the Current Opinion and Sociology 2019. Tranexamic acid and perioperative bleeding in children, what do we still need to know? There is a recommended dose of tranexamic acid 10 to 30 ml per kg, followed by a 5 to 10 ml per kg per hour infusion. However, maximal efficacy and minimal side effects dosage are still not very well studied and requires larger prospective trials and also should include high-risk groups. Under the same major bleeding coagulopathy European Guidelines Update 5th edition, in recommendation number 23, in terms of coagulation support, it suggests the monitoring and measures to support coagulation should be initiated immediately upon hospital admission. And this is evident by grade 1B. In terms of coagulation monitoring, recommendation number 23, it states that all patients should have early and repeated monitoring of hemostasis with more than one of the following: either a combined traditional lab test, a PT platelet count and fibrinogen level, a point of care test of PT INR, as well as viscoelastic modulation, whichever your institution has, right? With regards to DOAC and NOAC, so some patients that come in with rivaroxaban usage and major bleeding and dabigatran, we need to understand where it acts. So as for dabigatran, it has an anti-2A inhibitor, but for rivaroxaban, epizaban, it's an anti-5A, anti-10A inhibitor, right? Okay. SPAN has also documented in the Journal of Critical Care in 2019 basically a pathway to evaluate this sort of patients on DOAC and NOAC. The first is to determine what kind of anticoagulant the patient is on. But of course, we must say that these patients are having exsanguinating bleeding or major trauma requires transfusion. Subsequently, administering tranexamic acid 1 gram IV if not received pre-hospital. Administering fibrinogen 2 to 4 grams IV in severe cases. Further recommendation 26, evidence grade 1B, 1C, with regards to fresh frozen plasma-based management. If an FFP-based coagulation resuscitation strategy is used, the further use of FFP should be guided by standard testing. This is grade 1C. However, if the patient does not have major bleeding, it should be avoided. And the use of FFP should be also avoided if there is a treatment for hypofibrinogenemia. This is evidence grade 1C. Right. The causes of fibrinogen depletion in trauma includes blood loss, dilutional, consumption, hyperfibrinolysis, hypothermia, and acidosis, and this is well described by Schlimm in the Journal of Hematophysiology 2014. In the Journal of Injury in May 27, describes the fibrinogen as an independent predictor of mortality in major trauma patients, a 5-year statewide cohort study. And this is another study by Schlimm in the Journal of Critical Care 2013, which studies, sorry about that. Right, okay. So this journal in the critical care which studies the plasma level of fibrinogen levels that is associated with the base access of the patients upon the emergency room admission. And it states that the estimation of the plasma fibrinogen levels sort of concurrently can be related to the base excess. So they said that the base excess, if it's more than -6 millimoles per liter, in 81% of the population that was studied had a fibrinogen of less than 200 milligrams per deciliter, and in 63% of the population actually had a fibrinogen of less than 150 milligrams per deciliter. Right? What are the sources of fibrinogen replacement? You can use frozen plasma, fibrinogen concentrate, or cryoprecipitate. But you must understand there's a clinical consequences when you use the fresh frozen plasma. When the fibrinogen concentrate is very low, there's evidently a low HB as well that requires PEG cell transfusion and further diluting the coagulation and really further causing even more FFP administration, and this is just a vicious cycle. So the causes, in the FFP, we must understand that it has a very low fibrinogen concentrate and can be very variable from 1 to 3 grams per liter. Therefore, you need a very large amount to have a potential benefit for the patient, as well as understanding that the FFP actually has allergic reaction as well. So preferably to go for a fibrinogen concentrate, however, is more expensive, or evidently cryoprecipitate will be a better choice. Okay. So back to understanding the concentration of fibrinogen in the product, in FFP, you only have about 2.3 grams per liter per unit, whereas the concentration of fibrinogen in cryo is up to 12, and the fibrinogen concentrate is actually 20, and this was published by Cochrane in Stat Pills 2020. And also discuss about the volume, in FFP, volume per unit is up to actually 250 mils. In cryo, volume per unit is about 12.5 mils, and the fibrinogen volume per unit is about 50 mils. Okay. So back to the management of major bleeding and coagulopathy European Guidelines Updates, 5th edition, recommendation number 24. In terms of initial coagulation resuscitation, the initial management of patients with expected massive hemorrhage to use one of the either two strategies, the fresh frozen plasma or the pathogen inactivated FFP in an FFP to RBC ratio of 1 to 2, or just using fibrinogen concentrate and the PEG cell. Recommendation 8 in terms of hemoglobin, of course, we all know a low hemoglobin should be considered an indicator of severe bleeding. And it advocates at least a target HB between 7 to 9 should be evidently enough for critically ill patients. Right? For prothrombin complex concentrate, which is better, the 3-factor or 4-factor? Do they have any thrombogenic events to consider? Well, Shishan Hamidi and et al. Have described in the Journal of Shock in July 2019 that describes the 4-factor PCC is better. Evidently, it's because of the content of higher concentrations of factor 7 protein C. It also contains protein S and heparin, as well as some human albumin. In terms of efficacy, it reverses the INR very rapidly, therefore reducing any need for further transfusion, and there's also no increased risk of thromboembolic events. With regards to NOVA-7, recombinant factor 7A requires a hematoconsult and is usually used in hemophiliac patients who are having bleeding. FEBA is actually an anti-inhibitor coagulant complex. It's an FDA-approved drug. It's used in hemophilia A and B, and it's made from human plasma, and also requires a hematoconsult most importantly, right? For rivaroxaban, we must understand that pro-hemostatic agents are unlikely to improve any outcome in patients with a normal PT. So we only use it when patients are on this sort of drugs and they are requiring major transfusion, having major trauma. Otherwise, it's advocated not to reverse patients who are on DOAC. Dabigatran, antidote indarosizumab is advocated where the patients come in with major trauma and bleeding. But we also need to consider dialysis where excessively prolonged APTT of more than 80 seconds and dabigatran of more than 500 nanograms per milliliter and or impact renal functions, knowing that dialysis also can remove up to 60% of this drug within 3 to 4 hours. Okay. Back to the European guidelines, the 5th edition, recommendation number 25, in terms of goal-directed therapy. This is evidence-based grade 1B. Resuscitation measures should be continued using a goal-directed strategy guided by standard laboratory coagulation values and or viscoelastic modulation. The benefits of VEM over standard coagulation tests. Both provide rapid results. However, in VEM, we have a better understanding with regards to the clotting time, the dynamics of the clotting, as well as the quality of the clotting. Stein has published in the Journal of Anesthesia in 2017, entitled Change of Transfusion and Treatment Paradigm in Major Trauma Patients, which states that the following the implementation of goal-directed coagulation management and the change in other aspects of trauma management, the incidence of massive transfusion after trauma was actually reduced by 50% as compared to that predicted by the TASH score itself. Right. Another study published in the World Journal of Emergency Surgery in 2014 by Ying states that the goal-directed transfusion protocol by the standard TAG available, by the standard TEG achievable in patients with abdominal trauma as compared to the conventional transfusion management has the potential to decrease the blood product utilization and prevent further exacerbation of the coagulation function. Moore and Gonzalez has described in the Annals of Surgery in 2016, entitled Goal-Directed Hemostatic Resuscitation for Trauma-Induced Coagulopathy Maintaining Hemostasis, a pragmatic randomized clinical trial comparing VEA with a conventional coagulation assay, and states that the MTP based on the conventional coagulation assay actually led to more plasma and platelet transfused in the early phase of resuscitation and overall more precipitate as well as compared to the TEG that did not require unnecessary transfusion. Survival benefit was seen in the first 6 hours of ED that required less hemorrhagic deaths and less early deaths occurring in the TEG group as compared to the conventional group. And these patients from the TEG group has also benefited from ICU free days and as well as ventilator free days. Okay, this actually is a protocol at the OVA Trauma Hospital in Salzburg, Australia, that actually uses ROTEM as part of their MTP protocol. And so at the early phase, they have to optimize the temperature of more than 34 degrees, optimizing calcium always more than 1 millimoles, as well as hematocrit of more than 24%. In Denver, US, they actually use the protocol advocated by Moore, whereby they actually use the TEG as part of their massive transfusion protocol. Gonzalez and Moore further did another study in terms of management of trauma-induced coagulopathy with TAG, and they concluded that the TEG is the only clinical available assay that can detect fibrinolysis accurately and in point of care setting guided by the MTP. Why? Because they said that the platelet inhibition and the platelet dysfunction it's not really evident, at least seen clearly in the standard assays. This was published in 2018. Right. This is another very interesting study, the iTactic study that was conducted in UK that was participated by 6 trauma centers. Also published by Karim Brody, Baksas, and K. There was just came out somewhere last year. Actually had 3 different arms of patient. They had the major hemorrhage protocol in the system for all 3, but studied the usage of Rotem, TEG, and the conventional coagulation therapy to see which is better. And in the conventional coagulation therapy, how they managed was they always they felt that if the fibrinogen was less than 2 grams, taking a cutoff of 2 grams, not the usual 1.5. They gave additional 4 grams equivalent of fibrinogen or cryoprecipitate as a or cryoprecipitate to replace the fibrinogen. In terms of platelet, their cutoff was 100, and if it's less, to give 1 additional pool of platelets. And for FFP, if the INR is more than 1.2 and the fibrinogen more than 2 grams per liter, to give 4 additional units of plasma. Right. Interestingly, the outcome, the primary outcome at 24 hours, there was no significant difference between the viscohemostatic assay as well as the conventional coagulation targeted groups in terms of patient survival and free or massive transfusion. And even when you look at the secondary outcomes in terms of mortality within 24 hours, mortality at 28 days, median time to hemostasis, thromboembolism, 28-day ventilator-free days, as well as 28 ICU-free days, there were no significant difference in secondary outcomes as well. Herbert and Wolfgang further described in the Journal of Anesthesiology in 2016 with regards to goal-directed coagulation therapy that states that trauma-induced coagulopathy is not a uniform coagulation disorder. Resuscitation protocols that actually advocates a predefined ratio of blood products do not really fulfill the specific needs of the patient. The concept of the goal-directed therapy as catered to the individual hemostatic deficits changes because as well as the dynamic part of the patient changes as well, and it should be well versed with the patient's dynamic changes in terms of managing your trauma-induced coagulopathy. Right. This is an example of an MTP targeted transfusion protocol, a collaboration between the Trauma Services Emergency Department and the Transfusion Medicine of Hospital Sungai Buloh, which has 2 arms of the protocols, the massive transfusion protocol at one arm and the other arm of a targeted transfusion protocol, which gives the coordinator, you can select this pathway either ways, and whichever the patient deems necessary fit. And at any point of the protocol, any point of the proposed pathway, tailored as according to the patient's needs, you can either switch an MTP to maybe a TTP or an initial TTP to the MTP, whichever suits the patient, whichever suits the physician or the surgeon or the anesthesiologist, right? So in terms of MTP in Sungai Buloh, the second cycle has the 4-4-4-4 units, and the cycle is a continuous cycle as we all understand, whereas the targeted transfusion arm has advocated the use of the emergency O blood in the emergency department to use that first, and subsequently, based on whether you have your point of care test or your viscoelastic modulation assay to further see what the patient needs as to the next group of, as to ordering the next group of blood products transfusion for the patient. So, however, if at any point of the way, I like to emphasize whichever deems necessary fit, whether it's MTP or RTP, we need to have a balanced resuscitation for the patient at the end of the day. Okay. There's a preliminary data analysis of pre-RTP and post-RTP intervention. The pre-RTP, actually known as the targeted transfusion as well, that shows a 25% reduction in the blood products. So as you can see, for example, the PEG cell, not pre-RTP intervention is about 50%, and post-RTP intervention is about 25% reduction. So I don't know, it looks like the numbers are showing very good interventions, especially in this pandemic, whereby we have lack of blood donors, and we are advocating safe blood patient safety campaign. So maybe this is the way to go during this pandemic, right? And this is the proposed algorithm with the trauma services emergency department, pathologists, transfusion specialists, hematologists of the Kuala Lumpur General Hospital, that pretty much follows the same guide as the Sungai Buloh Hospital, using the ABC score of less than 2 of the or the test score of more than 24 to activate either one of the MTP and TTP protocol, whichever deemed necessary, hoping to be guided by your viscoelastic modulation, hopefully in the near future. So there will be more balanced and coordinated. And at any point of time where there is a difficulty in whether we should reverse whatever anticoagulant the patient is on, we are going to get a hemato consult on board as well. Right. So last but not the least, some take-home points for this presentation today. Knowing that 1/3 of all patients who present to the hospital with severe bleeding show signs of coagulopathy. Antifibrinolytics are still advocated as the early preclinical treatment. The extent of traumatic hemorrhage should be assessed, intervened for early hemostatic control. Trauma survivors in their initial injury transition from a hypocoagulable state to a hypercoagulable state, and this occurs from the beginning of the first 24 hours itself. Increasing fibrinogen levels is the focus of early care. You have the advantage of your cryo, or where applicable, your fibrinogen concentrate. Knowing the patient's history of the anticoagulant therapy is very necessary. RBC and FFP should only be used where you're targeting to increase the volume. Viscoelastic testing or point of care testing is essential for targeted transfusion or massive transfusion, and is the way to go. Last but not the least, remembering individualized, balanced resuscitation is the ideal damage control resuscitative course. I would like to thank Mascot for giving me the privilege to talk today, and thank you very much for listening.
Thank you very much, Dr. Ratini, for the very today regarding targeted transfusion therapy. Dr. Ratini, by the way, is emergency physician in HKL and now doing specialty in trauma emergency care. All right. Okay. For any question and answer, you can post in our chat box. Any question you can type it down in chat box, and question and answer will be saved after Dr. Sarojini's talk. For this is some housekeeping message. Registration will be given at the end of our session. QR code will be provided, link will be provided, and a certificate will be sent to your email. So please anticipate, and it's set to be sent to your email around 1 week time. Please check your spam or junk mail if the e-certificate is not applicable in your inbox. And registration QR code will be closed after 15 minutes of the event. Okay. Okay. Next is I would like to introduce Dr. Sarojini. She will be given a talk regarding revisiting the medical transition protocol. Dr. Sarojini is graduated from MD Moscow and had working as transfusionist in Hospital Sungai Buloh, Selangor, Malaysia. Okay. Without further ado, I would like to invite Dr. Sarojini to give the talk for today. Dr. Saru, the screen is yours.
Okay, thank you, Dr. Amira. Good evening to all. I would like to take this opportunity to thank everyone, the organizing team, for giving me this opportunity to give a talk on this topic. Okay. Hello?
Yes, we can hear you, Dr. Saru.
Can you see, yeah? All right, okay. All right. So my topic today is going to be revisiting the massive transition protocol in trauma, a back-end perspective. So the outline is going to be introduction to, hello?
We can't see your slides right now.
Oh.
Can you share your screen now?
Hold on.
All right, no, sure, no problem.
Now, can you see? Okay. Is it okay now? Okay, my the outline of my talk going to be introduction to massive transfusion protocol, MTP in trauma, Hospital Sungai Buloh, quality implementation project on wastage, introduction to new approach, we call it as a rapid transition protocol, outcome of the new intervention on wastage. So as we can see, as we all know, it's already, thanks to Dr. Ratini, she already explained most of the important issues regarding the massive transfusion and hemorrhage in trauma. So massive transfusion refers to any situation where a patient is getting a lot of blood transfusion. There are different definitions exist, but the common definition used is the requirement for more than 6 units of red cells in 4 hours. In trauma, hemorrhage is the most common cause of death within the first hours of arrival to the trauma center. Nearly 50% of deaths in the first hours after injury are due to the exsanguination and coagulopathy. So when we talk about normally massive transfusions are not unplanned. It requires the processing and delivery of large amount of blood products rapidly for sustained period of time, significant pre-planning, coordination between the transfusion service, the emergency department, and OT, mainly the NS team, and required delivery personnel. So as for definition, introduction to massive transfusion protocol, it referred to a rapid administration of a large amount of blood products in fixed ratios for the management of a massive bleeding cases. It has been developed to provide a rapid access to and administration of blood products in resuscitation to maintain the oxygen concentration, cardiac output, and circulating blood volume is necessary for survival. As for transfusion service, it is a management of blood transfusion requirements in major bleeding episodes, assisting the interactions of the treating clinician and ensuring the judicious use of blood and blood components. Actually, we can say it's a teamwork between the treating clinician, transfusion service, and the lab. The development of massive MTP, it should be a written document it should be based on the principle of damage control resuscitation, and it should be provided for ratio-based blood products and accessible to all and adopted by the center. All the staff should be familiar with the procedures. Initial training and subsequent regular drills are recommended to maintain the competency. MTP may be administered in following clinical areas like trauma service, emergency department, operating rooms, intensive care unit, even in the ward where the major bleedings are taking place, mainly in the ONG department. So the component of MTP, SBC, the first is when and who should initiate the MTP. Notification of the MTP activation. Notification of MTP deactivation. Required type of blood component package. In our information on required blood samples, flow on blood product preparation and also delivery, we have a predetermined transfusion packages. So as for MTP in Trauma Hospital Sungai Buloh, it has been widely adapted for the care of bleeding cases in trauma patient. Here in our center, almost nearly 4 to 7 MTP were activated per month. Most of the cases are trauma followed by ONG and surgical department. So this is our this is our protocol, documented massive transfusion protocol. As we can see here, we have the definition, massive transfusion protocol one, and we have also activation of the information regarding activation of MTP, who's supposed to be activate the MTP. For example, emergency physician or primary team specialist, consultant to inform the patient. So, and also we have ED or primary team memo to inform the blood bank MLT on call. Following that, we have information required by the blood bank. What are the information required by the details on must be given to the blood bank to be recorded, and the amount of sample required by the lab, and some notes informing as a reminder to inform regarding the flow of the MTP, and also availability of the blood product for collection in activation of MTP. As you can see here, we have given the detail of blood products, availability, and how to transport. And also in the middle, we have a flow of how the MTP should goes. First, we have activate MTP. We need to notify the transfusion lab, mainly to MO blood bank on call and MLT blood bank on duty. There's exception number 2154. And we have, since we would like to adopt this MTP for multidisciplinary departments, so we have divided, because certain cases they don't require cryo precipitate, so we have created code 1 and code 2. Code 1, there's no cryo, will be prepared. Code 2, there won't be, they will be included cryo, and the ratio will be 1:1. So we have for system wise, first cycle, second cycle, and third cycle. And the second cycle will be a continuous process from the first cycle. And the sample that we needed will be 10 mL in an EDTA tube. And finally, the information need to deactivate the MTP. So how does it work? At the clinical site, specialist or consultant or treating clinician will identify the trigger point to activate the MTP. Immediately, he will appoint a coordinator. Coordinator plays a very important role here, where he will be running the show. He will appoint a runner. The runner is in charge for delivery. He will be the delivery personnel. Immediately call the coordinator need to contact the transfusion service to activate MTP and choose inform code 1 or code 2 and provide details of the patient, name, register number, indication, and who activate detail of the specialist activated the MTP. And also have to ensure the sufficient blood samples sent to the blood bank immediately. Deactivation once bleeding secured and hemodynamically patient is stable. To complete and send the MTP tracking form to blood bank. We need the MTP tracking form to monitor the improvement, actually is for the performance improvement monitoring. This is our MTP tracking form as mentioned here. It made available in public folder for the clinician or coordinator to print it out and fill in to send to blood bank for the performance monitoring. What happens in blood bank during the MTP activation? So lab technician MLT receives a call for MTP activation. The MLT will fill up the details in the MTP request record. We have already assigned an MLT from MTP blood preparation on the day will take over. So this MLT will be locked only for preparation blood for MTP. He will review the history of the ABO grouping in the system while waiting for the blood sample. If the patient is a first time to Hospital Sungai Buloh, immediately we will start towing FFP and cryo, which it will be a universal plasma, which is ABO group. If the patient has 2 previous records on blood group, we will start towing the blood group, specific blood group FFP and cryo. Why are we doing this? Time is the matter. So when you look at it, normally to tow FFP product will take about 20 minutes. If we start waiting for the sample to receive and we start towing, it will take more time. In view of time matters, so we will start towing FFP ABO blood group. As for PEG cell, we still need a sample for cross-match. MLT inform medical officer transfusion service. MLT will inform the medical transfusion service. The MO will inform the transfusion specialist and follow up the clinical coordinator till the deactivation. So as for blood progression in hemorrhage, we have immediate, that is we call uncross match, that is O RHD positive, where normally, as you see in overseas and other countries, we are very sure they have seen that it will be O RHD negative. But due to our population, among our population is 2% out of the donors are negative, we are unable to place O negative as a uncross match emergency O. So what we are placed as is O RHD positive blood group, and it is placed in Hospital Sungai Buloh. We have placed the uncross match safe O available in ED. And then we have next is we have immediate spin specific blood group, which is less than 30 minutes. The only test will be done here is ABO and RHD, and we will do immediate spin and we will release the blood which is considered as first stage. As for full cross match, we'll be taking about 45 minutes where we will do a full cross match, ABO grouping, RHD grouping, and also antibody screening, and we will do the cross match. So review on the MTP activation in Trauma Hospital Sungai Buloh. Periodic evaluation and revision is needed to ensure the MTP protocol meets the objective and identify the potential improvement areas. Reducing blood product waste is a appropriate goal since it could preserve useful resources and reduce the overall cost. A retrospective study involving the transfusion service and the clinical teams important to evaluate the efficiency, performance, and outcome of MTP. So quality implement project on MTP activation. So when we talk about quality implemented, we have done a study where the aim of audit on MTP activation. So the aim of this study was conducted is to audit the MTP activation and use the obtained data to create a better approach to avoid improper activation and also blood product wastage. A retrospective analysis was performed on 84 MTP activated cases in Hospital Sungai Buloh between April 2018 till June 2019, where out of 84 MTP activated cases involving emergency department, that is around 69 cases, followed by OT, followed by OT, PAC, ONG, OTO, and ICU. Among the 69 cases activated in ED, the most of the cases are involving trauma cases, polytrauma. That is around 56 cases were reported. MTP was activated for 56 cases. So followed by ectopic pregnancy, antepartum hemorrhage, postpartum hemorrhage, and upper GI bleed. So the usage of prepared blood products by ED for trauma cases, total of 56 cases, we'll say is 54%. The product that we prepared was used up. Another 46% of the product was not utilized. So it shows us the conclusion was the blood product which were prepared for MTP activation was not fully utilized, and it contributes to wastage of the blood products, energy, and resources. So the MTP cycle ratio needs to be considered for changes to decrease the blood and blood product wastage. So we needed a further audit to establish a rational approach in managing the wastage of blood product in MTP activation. So the new approach intervention in massive transfusion. So it was a team effort where transfusion service with trauma team, we reviewed and analyzed of all the collected data together, discussion on quality implementation on wastage and new approach. We conducted a clinical intervention, analysis of the pre and post intervention data. So new approach, as Dr. Rakni has mentioned earlier in her lecture, Rapid Transfusion Protocol, RTP. It has been developed to provide early and standardized blood and blood components to deliver as required to improve the patient outcomes while controlling the wastage. So flexibility in RTP can be converted to MTP. It can be started as RTP, and if the patient is not stabilized and needed more blood products to continue for resuscitation, it can be converted to MTP, where we will be continuing with cycle-wise with the ratio 4:4:4. So the supply of blood and blood products are timely, but the supply of the blood and blood products will be timely as in MTP. So as you say, I already explained regarding the massive protocol earlier. So we made a decision to change the flow in between, where we wanted to make it as prepared as requested and no continuous process. Because in a MTP, the first cycle and the second cycle will be a continuous process. When we receive call for MTP, we will start towing the AB plasma. The first cycle will be released to the clinician. Meanwhile, we already started the second cycle, preparation of the second cycle. We do not wait for the signal from the clinician side. So, as for third cycle, only during the third cycle we will be waiting for the signal, and sample to continue for the next cycle. So we decided we need to do some changes in between the flow to, for example, we didn't want to do a continuous processing of the blood products. So the outcome of the clinical intervention on RTP. In earlier lecture, Dr. Ratni has already shown data analysis of pre-RTP and post-RTP intervention, where she has mentioned that actually that data is overall for MTP activated in Hospital Sungai Buloh. This data mainly is only for activation of RTP pre and post intervention outcome in ED, Hospital Sungai Buloh. So as you can see here, the PEC cell is still the same figure, where not used prepared blood product MTP, pre is 48%, not used prepared blood product MTP and RTP, post RTP, also same. Most probably the factor that affecting here is the usage of the uncross-matched SAFE-O in ED, which has effect on the reduction of the preparation wastage of PEC cell. Also, same goes to platelet, where you can see it's a 50%, reduction is about 46%. So, and cryo 45 to 42%. But significant reduction seen in FFP, where 56% the reduction is reduced to 45%, about 11% as reduced. So this data was collected from August 2019 to December 2020. Okay, constantly identify weaknesses. So we identify more weakness in our application, where we decided due to poor planning, poor communication, infrequent lab monitoring, delay in ordering, for example, unmanaged sample, incomplete request form, and also delay in receiving blood sample, hemolyzed blood samples, and restriction of lab system. Because restriction of lab system mainly because delay in receiving blood sample, where we are unable to key in the blood group. Due to that, we cannot release the FFP and cryo, the prepared FFP and cryo, due to the system. So further improvement action needed. So we need to revise the outcome of the patient, timing of the deactivation, review the trigger points to initiate MTP and RTP, documentation of the protocol. So after the review of all, it is possible for us to make a documentation of the protocol since we do not have we haven't created actually a proper protocol. As Dr. Ratini has shown earlier, we have a flow, but we need to create an documented protocol after the full revision. So when we talk about highlight on activation of the MTP and RTP and usage of uncross-matched SAFE-O, the misuse of MTP and RTP activation as a fast route to obtain the blood and blood products. Most of our cases, RTP and TP, we have noted, mainly MTP noted that is the first cycle. Once completed first cycle, immediately it was deactivated. The reason, they say patient already stabilized, but the reason why we are consider this issue is because MTP is a continuous process. When we didn't know, we are not aware about the blood group, we start throwing the AB plasma. The ideal universal plasma is AB plasma, but unfortunately is in short supply due to limited percentage of donors. As a result of increasing use of plasma in resuscitation, shortage of plasma may occur for the patient with AB blood group. So we need to consider about that. So the trigger points to activate NTP need to be revised. So to ensure that proper NTP or RTP is done. Pre-transfusion sample of uncross-matched CFO is very important because due to the emergent need for blood products, routine pre-transfusion testing is bypassed. This will put the patient at the increased risk for acute and delayed hemolysis due to the alloimmunization. So it is a compulsory that pre-transfusion sample should be collected before using the uncross-matched CFO. So as a point, I can say take-home message is NTP and RTP is, the intervention of RTP is still ongoing. We need to look into all the factors that need to overcome, and we come up with the improper RTP activation documentation should be done. Otherwise, I think that's all for now. I'd like to say thank you. These are my reference. Thank you.
Thank you very much, Dr. Sarojini, for very informative information regarding NTP. Okay, now we're going to proceed with question and answer session. So Dr. Ratini and Dr. Sarojini, can you on the video? On the video.
Okay, hold on.
Dr. Sarojini can stop sharing the slides first.
Okay, hold on. Okay.
All right. Okay. So here, I have a question from Dr. Sabaria to Dr. Ratini. Is there any study to look into the outcome between MTP and RTP?
Yes.
Ratini?
Carry on, Amira. With regards to Dr. Sabaria's questions in terms of are there any evidence-based studies comparing the MTP with the targeted transfusion protocol? Well, globally, as quoted by Moore, Gonzalez, Stein and Hibbert in the Journal of Anesthesiology 2017, most, and the one in UK, the iTactic one, evidently the US, the UK, Austria actually proposed to use the MTP as the initial part of resuscitation for major trauma, and subsequently correlating with point of care test or viscoelastic modulation, of which Moore and Gonzalez actually clearly described that their patients benefited more from the TEG. However, in Denver, whereas in Denver, US, they preferred the TEG as well, but the one in Austria preferred the ROTEM pathway, but the protocol was still following the MTP. Even the iTactic study that was conducted by Karim Brohi et al. In UK actually evidently used the massive transfusion protocol as the initial part of stimulating it, meaning which they actually advocated either, depending on institution, whether it's a 444 or a 666, and then subsequently guided by their viscoelastic modulation, where using the ROTEM TEG or your point of care test. The only thing is the iTactic clearly described that there was no primary and secondary outcome that significantly differentiated between all the three arms. So in our current setting, I feel that it's not going to be easy for somebody to straight away describe the ratio of blood products required for a patient at the initial part when the patient comes in major trauma examination. So preferably in this sort of patients, you have the privilege of activating your MTP protocol first, subsequently as the initial phase, and then guided gradually by your viscoelastic or how your patient continues either attains a dynamic better control or is deteriorating, then you can either decide whether you want a more targeted or you want to continue with the MTP. So this is what the global discussion is about at this point. But as for now, I couldn't find any studies that starts with a targeted transfusion as the initial line. But what I'm trying to say is, I guess you have to go clinically and see what the patient needs evidently in the end of the day. There's actually a second question that asks regarding pregnant patients, whether you use the same protocol, what is better. In terms of pregnant patients, we have to understand that pregnancy itself is a state of an increase in cardiac output, an increase in is a hypovolemia state, whereas the baseline heart rate of patients are usually more than 15% of their heart rate is more than 15%. So the moment they come in with major trauma, exsanguination, I'm talking about pregnant patients, automatically, I think that evidently you go towards the line of activating your massive transfusion protocol advocated by your institution. So that will be the way to go.
Okay, thank you, Dr. Ratini, for the answer and for the feedback from all the questions that has been given. Okay, now Dr. Sarojini, I have actually got one question from Muhammad Halis. He asked about what shall be the management of leftover or unused MTP blood product after we have declared stand down to the MTP activation. Shall all be returned back to the blood bank? Okay.
Yes. Once they stand down, if this blood bag is not used, they will be returned back to us. The packed cell, we will check the condition and quality of the packed cells. If it can be reusable, we will put it back in the donor pool. If not, we will reserve for the same patient. If in a good condition, we will reserve for the same patient in future use in the ICU or this side. We will hold it for 24 hours. And then we will put it back. Once the confirmation from the treating clinician, no use for the blood, then we will release back to the donor pool. As for FFP and cryo, unfortunately, we cannot refreeze. So we have to discard the product. As for platelet, if it's in a good condition, we still can continue. If it's not, it's longer the time period of kept in the outside normal temperature, we need to discard already. So depending on the condition of the quality, but unfortunately, FFP and cryo, we have no choice. We need to discard the product.
All right, thank you for the answer. Dr. Saru, what do you think? What is your opinion regarding replacing FFP with PCC in the maybe in the future? What do you think about it? Because we can save time actually about 20 minutes. Because for FFP we have to talk about 20 minutes, then we can use it after that. Kan kalau PCC we can use it like right away after that. So what do you?
Yeah, and from my point of view, there is some. We have to look into the studies and all that to judgment what is a complication it can be caused in trauma, because each massive bleeding can cause different way. My trauma might be different. So I think we need to do a revision and so on to make a decision regarding that.
Okay, thank you, Dr. Sarojini. Okay, I have one more question to Dr. Ratini. In your experience of using TTP, what are the challenges during resuscitation and how you overcome it?
Okay, thanks for the question, Amira. Basically, in activating TTP, the first question will arise is, what should I start with? So it always depends on how your patient presents with as well. So I guess you'll have to weigh the risk benefit. For not all patients come in the same. So it depends on individual basis, but you need to really thoroughly understand what goes best for your patients. most patients that I have experienced do well with the targeted transfusion protocol so far. By the second cycle, they seem to do pretty well in terms of dynamic stability. So I guess that's a way to go. But on the other hand, there are definitely patients there as well that have also benefited from the massive transfusion protocol. So I think it's still an ongoing study. There are lots of controversies. There's lots of debates. There's no one protocol fits all.
Yeah.
So at the end of the day, we are always aiming for an individualized, balanced resuscitation for our patients.
All right, all right. Okay, thank you, Dr. Ratini. Okay, now it's already 7:20 p.m. We promise our CME will be until 7:15. We don't want to drag it anymore. I know there's a lot of question at the chat box, but we promise we will try to answer and post it at our Facebook, Malaysian Trauma Conference Facebook. So after this, maybe all the participants who wants to know the answer can check our Facebook. Okay, now we come to the end of our session. I would like to remind again regarding the registration. I will give, I will show the QR code after this. So please register. Please register by scanning the QR code. It will be sent to your email. Please anticipate around 1 week time. Check your email. If there is no inside your inbox, please check your spam or junk mail. And this registration will be closed after 15 minutes of the event. Okay. Have a good evening, everyone. This is the 6th of our CME. Next month, we will have a new topic. See you next month.
Thank you.
Thank you very much.
Thank you.
Everyone.